Retina UK is the only UK charity dedicated solely to working for people affected by inherited sight loss. Our vision is a world where everyone with inherited sight loss is able to live a fulfilling life. We're here for you. The Retina UK helpline have a team of volunteers who have personal experience of inherited sight loss. So whether you're looking for practical information or emotional support, we can help. Just call 0300 111 4000 or email helpline@retinauk.org.uk.
I live on my own, and most of the time that's okay. I like it. But through lockdown, there are times that I feel lonely. I have those days, the stress of everything that's going on. But this has been really helpful speaking to you. I will call again. Thank you.
Talking to Retina UK and the person on the talk and support line, he went to football matches, so I pushed myself to get out and about. Now I catch a bus to work on my own. You have to readjust. That's what I've done. Meeting Retina UK and the staff, that it gave me the confidence to go out and have an interview, which I'd never had before.
So that's incredible. Now you're actually helping other people.
I've come a long way on my journey. The talk and support has helped me do that.
Our talk and support service matches those who would like a regular chat with a friendly volunteer who is also affected by inherited sight loss. Why not find out more from our website?
Volunteering with Retina UK offers an opportunity to grow. You retain your sense of value, become more confident, and learn so much more yourself while helping others. It's tremendous, and I'm really pleased that I've been able to do it.
Visit www.retinauk.org.uk. Email info@retinauk.org.uk. Call 01280 821 334.
Good morning, everybody, and it's my absolute pleasure, through the magic of technology. Not only have I managed to change my background, my hair and my top in 2 minutes and 30 seconds, but I also get to welcome all of you here today. So let's get going with our first session, which is all about genetics. We have two marvellous presentations for you. Firstly, Dr. Sergouniotis is going to present to us, followed by Kate Arkle and Denise Warden from the Retina UK team, who will be presenting all things genetics and unlock genetics, which I presented to you a few moments ago. Please ask questions. We will be having a Q&A directly after the presentations. So please email us on info@retinauk.org.uk or telephone the team, who are all ready to take your calls on 01280 821 334. So without further ado, please welcome Dr. Sergouniotis. Thank you.
Good morning. I'm delighted to join you at the Retina UK Professionals Conference 2021. My name is Sergouniotis, and I'm an ophthalmologist and a lecturer at the University of Manchester. Today I'm going to talk to you about genetic testing in inherited disorders of the retina. I will start with a brief overview of my presentation. First, I will talk about genetic testing in general, and then I'm going to focus on some new developments, some new information about how genetic testing can be accessed, and then I will finish with some examples on why genetic testing is important and impactful in people with inherited retinal disease. First, I will start with some background, and let's start with a cell. Cells are the basic building blocks of all living things. In a human body, we have trillions of cells, each with their own specialized functions. a cell in a person's body has a unique set of instructions, and all the cells have the same set of instructions, so the same manual, the same kind of a bit like a recipe book on how to make a human being. Now, this set of instructions, it's unique for each individual, and it's encoded into DNA. What is DNA? DNA is a long molecule that if we take the DNA from a cell and we stretch it, it will be up to 2 meters. And it's all made of 4 building blocks, 4 letters, as we call it, G, A, T, and C, Gattaca. Those are the basic letters that build DNA. So these letters are arranged in sequences, and what I'm showing here is a graphic representation of a sequence. So if I take all the DNA from my body and compare it with the DNA from someone else, will be pretty similar. So 99.9% will be similar. But if we look, we can find some differences as well. So where one person would have a T, the other person could have a C. Now, we like to describe these differences as misspellings. So if we think of all our DNA, our genome, as we call it, as a book with 3 billion letters, if we look and compare this kind of instruction manuals from different people, we will find that they're different at various positions. So we all have changes scattered throughout. So where one person could have an A, the other person could have a G. Now, most of these changes are innocuous, they're benign, they don't have any impact on the function of the cell. But rarely, what these changes can do is they can have a significant effect. So, for example, a single spelling mistake will be the cause of cystic fibrosis. We are now able to read the DNA, read the sequence of letters in the DNA and identify the spelling mistakes. And this is what we call DNA sequencing. I would just like to spend a minute to talk about DNA sequencing, and more specifically the cost of DNA sequencing. I'm showing a graph here where on the one axis you can see cost in logarithmic scale, on the other axis you can see years. So it goes from 2001 to 2020. And what this graph is showing is that there is a drop in price, so we're doing quite well to reduce the price up to 2008, and then it completely went down. So it became very, very cheap. And that's because new technology was introduced, what we call next generation sequencing platforms. So these were machines that could read DNA, that could sequence DNA much more efficiently and much cheaper. So we're now at the position that we can look back at the past 20 years, and we can see that the price of DNA sequencing has dropped 100,000 times. This is a remarkable technological advance, and not only in the biomedical field. So this has transformed the way we do genetic testing. This has transformed the way that we diagnose people with inherited disorders and how we manage them. And also had an impact on how we design our services. One recent change in the services that was introduced a year ago was the NHS Genomic Medicine Service. So this was an England-wide initiative, and there's a Royal College white paper on that. But essentially what this service was intending to do is to provide centralized funding for testing inherited diseases. So any patient with an inherited retinal disorder is eligible to be tested. They can go to their ophthalmologist in their local hospital. They don't need to go to the super specialist center. And from there, what they can do is they could provide a blood sample. Their doctor needs to fill in a form, and that is the test being sent. So it's that straightforward. There's no complication about what are the details of the test that needs to be done, where funding will come from. This is a centralized funding, and once this thing happens, then the sample is sent to one of the 3 laboratory hubs for eye genetic testing, as we call it. So you could, so it would either be sent in Manchester, it could either be sent in Oxford, or it could be sent in London between Great Ormond Street and Moorfields Eye Hospital. Those are the 3 big genomic laboratory hubs. And that's where the sample will be analyzed, the results will be interpreted, and the report will be generated and fed back. So it's much more straightforward. There is no postcode lottery. There are no excuses from clinicians that they can't access funding or it's tricky. It's the same for everyone. And that's what this infrastructure was intending to do, just to provide this equity of care in terms of genetic testing. So we talked about what genetic testing is. It's about reading DNA, looking at the DNA for changes that would have an impact on human health. We discussed about this new development in the NHS where genetic testing is centrally funded now, and it's much more easy to access. What I would like to talk about in the last part of my presentation is why would one want to have genetic testing? Does it make any difference? And that's what we call clinical utility, and it's about whether a genetic test affects the health outcomes, so does it have an impact on visual disability? And the answer is yes in some cases, because the test can allow access to certain treatments. Does it lead to any change in management? And again, the answer is yes, because clinicians could use this information to arrange more investigations or to arrange appropriate follow-up. And it's also very important to individuals and families for reproductive planning, life planning, etc. So I'm just going to discuss these themes in a little bit of detail and provide some examples just to try to make it a little bit more concrete. First, I would just like to point out that in Manchester we have a fair bit of experience in doing genetic tests. We've been doing that for 15 years. We have tested more than 10,000 people with inherited eye disease, and we're getting referrals from all over the world. As you can see in these maps, we're getting lots of referrals from Australia, Finland, and from all over the UK. We're not just testing inherited retinal disease, we're doing tests for other disorders. These are available as well, so testing for cataract, congenital glaucoma, things like albinism. And we find that genetic tests help these people a lot. We recently published our findings on a group of people about how genetic testing benefited them. This is an open access paper. I encourage you to have a look. We try to make it as readable as possible, and it's just about how genetic testing can affect the care and the life of people with inherited eye disease. Now, for this presentation, I would like to focus on inherited retinal disorders. I don't need to tell this audience very much about this. It's the commonest cause of visual impairment in the working age population, and it has significant impact on individuals and families, and it's largely untreatable. So, genetic testing in inherited retinal diseases. The first thing we would like to check is, are we getting answers? And indeed we are. So when we do genetic testing one person, there's an 80% probability of getting an answer, so finding what is the cause of their diseases. Of their disorder. So that's quite a good pickup rate, and we're able to provide answers and to pinpoint where the specific abnormality is at the molecular level. So genetic testing is informative, but is it usefully informative? It's usefully informative in many ways, we think. I would just like to highlight three specific ones in the next few slides and just show some examples. First, it's useful to gives us some clues about what the future holds, so it can help us refine prognosis. For example, there's this person that was in clinic a few weeks ago. It's a 31-year-old female who has retinitis pigmentosa. Most of you would be familiar with retinitis pigmentosa. It's an inherited retinal disorder associated with degeneration, first of the peripheral retina, and in some cases, the central retina also gets involved. Now, when we test at that age group for retinitis pigmentosa, we can find mutations in various genes, but there are differences between the genes. So if, for example, we find mutations in a gene called MAK, we know that these people, the deterioration of their visual field is pretty slow. So most of people with mutations in this gene would keep their vision till their late 60s. So they would keep their central vision till their late 60s. So the constriction of the field would be slow. In contrast, other people, we could find mutations in this gene called EYS, which we know that it tends to progress a little bit more rapidly. So the field tends to constrict a little bit more. And on average, people with mutations in this gene would lose their central vision by age 40. So that's important information. It's important information for the individual. It's important information for the clinician. It's important information for putting the support around and in many aspects. So it reduces uncertainty, and we can give some more information there. But perhaps our ability to figure out the prognosis is more striking in the younger age group. So, for example, here is a 1-year-old an infant that had nystagmus and abnormal visual behavior. So the initial diagnosis was that of Leber congenital amaurosis. This is perhaps a more severe end of the inherited retinal disease spectrum, where you have abnormal function and structure in the retina typically, and this tends to get progressively worse, leading to severe visual impairment. Now, when we did genetic testing in this person, we found mutation in a gene causing achromatopsia, which is a different inherited retinal disease that is stationary. And that matters because we can go to the family and say, like, well, the way it is now, it's likely that it's going to stay. It's not going to get worse. And there's a certain level of vision that you will be able to achieve rather than have this progressive deterioration happening over time. And again, that's quite a common scenario because we see lots of infants that they have nystagmus and they have normal visual behavior, and we think that they have this kind of progressive retinal disease. But when we do genetic testing, 1 in 4 we're figuring out that we are wrong, and in fact they have a stationary condition. So we believe that it's very useful for the diagnosis and for prognosis in this group. So I would now like to discuss a different thing where we see clinical utility of genetic testing, and that's when we're able to diagnose a syndromic condition, a multi-system condition. So that's we have certain disorders where the eye is part of the whole picture. There are other organs that might be involved, and genetic testing can help us identify this. I'll just show you an example. So a 24-year-old male with retinitis pigmentosa. This is a consultation that we've done 10 years ago, and we've been following him up already for a number of years with this diagnosis. So when he came to clinic, we had a look at the back of the eye, and we could see the usual changes we see at the periphery. But we also saw something unusual, and those these little bleeds around the blood vessels at the back of the eye, and that you don't really see with retinitis pigmentosa. In fact, this usually points out to some problems with the blood pressure. So what we did is we took this person's blood pressure, and we found that this was very, very high. So the next step was to do some tests about the kidney function, and that looked very abnormal. This person had kidney failure. So then we requested an ultrasound of the kidneys, and there was the kidneys looked small and abnormal. So this person was started on dialysis and was added on a transplantation list, and 3 years later they had successful transplantation. When he returned to our clinic many years later, we offered him genetic testing, which is what we do now for all our patients with inherited retinal disease, and that's what many centers do and what many centers should do. And we found, interestingly, a mutation that is associated with retinitis pigmentosa, which is the eye problem that this person has, but it's also associated with kidney problems. So if we have done genetic testing in this person some time ago, maybe we could have perhaps predicted the kidney abnormality. And this is exactly what happened in this 12-year-old male patient, also had retinitis pigmentosa. So this boy presented to our clinic, and we offered them genetic testing straight on, and we found this mutation that explained retinitis pigmentosa, but it also highlighted that there might be kidney abnormality. So we called the family, we brought them back, we checked the blood pressure, and that was fine. We checked the kidney function, that was slightly abnormal. We looked at the structure of the kidneys, and they looked small and malformed in keeping with this condition, which is called senior Loken syndrome. So this boy was started on dialysis, and 1 year later he had successful transplantation from his mother. And this matters. And the reason why it matters is that we know that if you go into this acute kidney disease stage, like our previous person with a very high blood pressure and severe kidney abnormalities, then this is an established predictor of poor outcome, and that means that you're losing years of life. So the fact that we could find that early and we could act on it was quite important, and it will have an impact in this person's outcomes over time. The third thing that I would like to highlight is that doing genetic testing has implications for treatment. Most of you would have heard that treatment for a specific subtype of inherited retinal disease called RPE65 retinopathy is now available through the NHS. This is not trials, this is not an experiment, this is an approved NHS-funded treatment. But to find the people who are eligible for this, we need to do genetic testing. And it's only, if we do 30 tests, we'll be lucky to find one that would have this, but that's the only way that we could detect. So essentially, when we see these people now in clinic, we can say there's a small chance that there will be an NHS-approved treatment for you, and to know whether you're eligible or not, we need to do a genetic test. And that's a very strong motivation, and that's why we're just quite keen for genetic testing to be offered more widely to people, because that's the only way for them to access this NHS-approved treatment. You will hear more about this treatment from Professor Bainbridge later on today. So those were some key benefits, but of course there are others. This genetic test can lead to resolution of uncertainty. We can get a specific diagnosis for an individual, and they can understand their condition a bit better. They can read about it. They can have something concrete in terms of diagnosis. And that can help with life planning, with reproductive planning, and so on and so forth. And in some cases, it will be informative for what we call reproductive decision support. So for certain inherited retinal diseases, what families can do is that they can have pre-implantation genetic diagnosis, which combined with in vitro fertilization IVF, we could select specific embryos that have a specific genetic profile to reduce the risk of having disease. And that's something that families with certain inherited retinal disorders can be offered. So to conclude my presentation, I just want to stress that genetic testing is now widely available. So the barriers that were there for many, many years have now been lifted through this new structure that has been adopted in the NHS since last year. So you can go to your local ophthalmologist, you can have a genetic test, and that will go to a specialist center, and there will be an answer. I also wanted to highlight that genetic testing has clear clinical benefit, and I've outlined some scenario. The ones to highlight is the risk to other organs in the body that we can sometimes identify, and more importantly, access to approved NHS-approved treatment, Bardet-Biedl that I discussed before, but also access to treatment trials that are ongoing, and there are really many of them at the moment. And the question that I keep wondering, and it would be great to discuss in an interactive session, is how can we reach all affected families? And that's about offering genetic testing to all eligible families. Of course, some would choose not to have it, although there are very strong arguments and strong benefit for having a test. Thank you very much, and looking forward to seeing you all in the interactive session. Many thanks.